We're going to talk about diabetic emergencies today. So some statistics on diabetic emergencies. About 7% of the U.S. population has diabetes. From the years from 1992 to 2005, about 5 million ED visits for hypoglycemia, and during that same time period, about 750,000 ED visits for diabetic ketoacidosis. Diabetic emergencies account for anywhere from 3 to 4% of EMS calls. I know sometimes we think we see a lot more diabetic calls than that, but as a general rule, about 3 to 4% of our call volume is related to diabetic emergencies. If you look at a definition of hypoglycemia and hyperglycemia, as a general rule, looking at our protocols, hypoglycemia in an adult is blood sugar less than 70, on a pediatric less than 60. And then hyperglycemia is a rough estimate greater than 200. Now I know sometimes when you go to the doctor, they'll tell you anything over 140 is considered hyperglycemia, but as a general rule, anything over 200. And those statistics are somewhat I guess surprising to me. I would have thought that it would be more than 750,000 DKA patients during those timelines. I would have thought it would be more than 7% of the U.S. population that would have diabetes, but those are basically numbers that are somewhat surprising. So what about hypoglycemia? We see a lot of those patients. I think the primary thing that we see again is that these patients don't wake up in the mornings. Their family tries to wake them up, and we see that a lot in the mornings. They go in, and when we arrive on the scene, the blood sugar's low. So how do we treat hypoglycemia? As we all know, we give them some type of sugar-containing fluid, D50. And when there's a shortage of D50, we may give them D10. Some services are going straight to D10 and not using D50. But if you look at the statistics, more oral glucose is used for hypoglycemia than any other sugar-containing solution. So if they are able to take oral meds, they're conscious enough, then I think you can certainly start with juice, glucose paste, etc. Most of the time when we get on the scene, though, the family's already done that. So by the time we're called, they're still in need of something more than just oral glucose. Again, I mentioned D10. There's a shortage of D50 at this point in time. So people are going to D10 from an Alabama EMS office. We approved D10 several years ago. So services can use D50 or D10. So how do you give D10? Everybody pretty much knows how to give D50. Basically it's an amp of D50. So what about D10 for those services and those people who are not familiar with it? I think that D10 is sort of a guess factor for lack of better terms. I usually give about 250 cc's of D10. And just sort of watch their response, and you can actually give up to 500 cc's. I always worry about those patients with congestive heart failure if you're giving too much fluid, but again, I think 250 cc's is certainly not going to hurt anyone. What about glucagon? Well, glucagon is one of those meds that if you can't get IV access or IO access, and most time we can certainly get IO access, but certainly IV, if you can't get IV access, then glucagon is a drug that you can give IM that will get their blood sugar up. The problem with glucagon is it takes anywhere from 10 to 20 minutes for it to work, whereas D50, D10 is going to work pretty quickly. On the pediatric side, if you remember, we give D25, and the dosage of that is 4 cc's per kilogram. What about hyperglycemia? Now, we've talked about hypoglycemia, now let's talk about hyperglycemia. We see a lot of those patients. Many times your glucometer will read just high. It won't give you a definite number. So what's the pre-hospital treatment for hyperglycemia? Certainly the number one treatment is IV fluids, just IV fluids, IV fluids, IV fluids. Many people will tell you that a blood sugar over 250 equals some component of dehydration. But we see a lot of patients that are hyperglycemic and that are symptomatic from that. So IV fluids, now we don't carry insulin. Some of the care services do carry insulin, and you can certainly give insulin to get your blood sugar down. But day in and day out, I would really highly recommend giving IV fluids to these patients. And you can give, 500 cc's, liter of fluid. Again, many of these people have comorbid conditions such as congestive heart failure, renal failure, etc. So you need to be careful with that. You may want to call online medical direction to get some idea of how much fluid you can give. But as a general rule, the treatment for hyperglycemia in the pre-hospital arena is IV fluids. DKA, I talked about that. Many times you really won't be able to definitively diagnose DKA in the field, but you can get a pretty good idea of that by, one, blood sugar is high, a history of nausea, vomiting last few days, they can't take their insulin, dry oral membranes, they're tachycardic, sometimes these people will be confused. Some people can smell the ketones. I personally cannot. It's a genetic trait. Many people can smell the ketones when they walk in the house. I don't have that ability or gift to do that. But if you can smell it, it's a telltale sign of DKA. Again, DKA, IV fluids, I'd suggest getting an EKG. Many times these people may have a myocardial infarction that tips them over the edge and makes them go into DKA. What about treat and release protocol? I know that some people have probably heard of the treat and release protocol. We don't necessarily have a treat and release protocol in the state of Alabama. And that's something that certainly I think we need to look at, and certainly something that we will be looking at in the future. Many of these patients don't want to come to the hospital after you wake them up. Some studies will show that anywhere from 35 up to about 65% of patients after you wake them up will refuse treatment. That's not unheard of. Throughout the nation, it's pretty much a standard sort of a percentage that many different places have looked at. Most of these patients, once you wake them up, obviously they don't want to go to the hospital. They prefer being treated at home and being left at home. I think that's fine. I think there's some things that you have to keep in mind to keep yourself safe from legal action, keep your service safe from legal action, and ultimately, and most importantly, keep the patient safe from harm. So how do you safely discharge from EMS care those patients that have been hypoglycemic and you've treated them on the scene, they've returned to their baseline, and now they don't want to go to the hospital? Well, one, they have a history of insulin-dependent diabetes. Now I know some of these people are going to be on oral medications, but they need an insulin-dependent diabetic history. They have to return of their normal mental status after the treatment and within 10 minutes of treatment. Their pre-treatment blood sugar needs to be less than 80, and their post-treatment needs to be greater than 80. I know that's a little bit of a difference in what our definition of hypoglycemia in the state of Alabama is, but this is sort of a national treat and release protocol that many people follow. They tolerate food by mouth. They don't have other complicating factors or comorbid conditions. Now again, that's going to be sort of the thing that probably gets some of these people a ride to the hospital, is that many of these people do have comorbid conditions. They have complicating factors, such as renal failure. So these patients may not qualify for treat and release. They need to have normal vital signs. I'd suggest having a very reliable family or friend with them. I would not leave these patients by themselves. And the other thing that you need to keep in mind, the sulfonylureas, which are a certain type of oral diabetic medications, those are long acting. So if they're on those, and metformin is one of those, or glucophage, I would suggest not treating them and them not transporting. Those are long-acting medicines. You're going to give them the D50, you're going to give them the D10, you're going to wake them up, they're going to be fine, and as soon as you leave, 45 minutes, an hour later, their blood sugar is going to be low again. So those patients need to be transported, and many times in the emergency department, we will watch those patients for up to 24 hours to make sure it doesn't drop. Now, I mentioned renal failure. Renal failure is something that can certainly predispose you to prolonged hypoglycemia. And patients with renal failure, they just can't clear the insulin, so their insulin will just sort of stay in their body and continue to work and continue to drop their blood sugar. So renal patients, you need to really be careful even contemplating not transporting renal patients who have been hypoglycemic on the scene, because many times that medicine is just staying in their system, not clearing from the system, and it will continuously cause low blood sugar. Those patients will again wake up and will be fine when you give them the D50 or D10, but 30 minutes, 45 minutes later, they're going to be low again. So those are patients you probably need to encourage to go to the emergency department. So what are our take-home points? Diabetic emergencies, certainly something you're going to see almost daily in the pre-hospital area. Hypoglycemic patients, less than 70 in an adult, less than 60 in a pediatric patient. Oral glucose, if they can tolerate oral medications, if they're conscious and alert, they can swallow. If they can't, D50, D10, D25 in a pediatric patient. Hyperglycemia, fluids. Remember DKA. You really got to have a high index of suspicion for DKA. Some telltale signs are dry membranes, high blood sugar, confusion. If you can smell the ketones, I can't. Treat and release. Remember, long-acting medications such as metformin and glucophage probably do not need to treat and release. You need to transport those patients, renal patients as well. Thank you very much.